আগের দিন যেগুলো পড়িয়েছিলাম কেউ কি গিয়ে দেখেছো বই থেকে? Did anybody have time to look through congenital anomalies? কেউ সময় পেয়েছিলে আগের দিন দেখার? ক্লাসের টপিকগুলো কিছু দেখেছিলে? শুনতে পাচ্ছ সকলে? শোনা যাচ্ছে? কেউ দেখেছিলে আগের দিন? আচ্ছা। So today we shall discuss a few specific congenital anomalies which are very common in clinical practice, and as medical graduates you should have a basic idea about these anomalies. This you will definitely encounter in your lives some way or the other, whichever specialty you eventually belong to. First two topics I have discussed in brief in the last class. I will just go through them again before venturing on the more important topics. So ureterocele. Ureterocele, I have discussed briefly the developmental problem that leads to ureterocele and what are the other anomalies associated with ureterocele. What are the presentations? Can anybody volunteer and tell me? Does anybody remember from the last class what is an ureterocele? তোমরা সকলে ফাইনাল ইয়ার ব্যাচ তো? হ্যাঁ? Yes. আচ্ছা, does anybody, I don't remember the faces this time. Does anybody remember anything about ureterocele? Will anybody volunteer? Okay. So ureterocele is a saccular dilatation of the lowermost end of the ureter. Lowermost end of the ureter where it enters into the urinary bladder. Why does it happen? It is attributed to improper canalization or incomplete canalization of the terminal end of the ureteric bud. Is there any recollection of these things? Ureteric bud, ureterocele. I would like some kind of a response from your end. Is there any recollection? No. Okay, so I am assuming there is no recollection. I will go through it again. So there is incomplete or delayed or improper canalization of the lowermost end of the ureteric bud. The ureteric bud, the structure which opens into the cloaca, okay, which arises from the mesonephric bud which opens into the cloaca. So this improper canalization leads to a cystic dilatation of the lower. এটাতে পয়েন্টার আছে? এটাতে পয়েন্টার আছে? কোনটা টিপলে? কোনটা এইটা? Okay, so it leads to cystic dilatation of the lower end of the ureter and the opening becomes narrow. So what does this lead to? It leads to obstruction to the flow of urine, and this obstructed flow of urine gets assimilated in this cystic structure. It is of several types, but basically we need to know whether it is limited to the urinary bladder or this dilatation has progressed beyond the bladder and into the bladder neck or beyond the bladder neck. So it can be intravesical, which is confined to the bladder, and ectopic, which extends to the bladder neck or beyond the bladder neck into the urethra, eventually obstructing the total flow of urine from the bladder into the urethra. Okay. So how do these patients present to you? These patients present to you, don't talk so loudly, I can hear your voices more than my voice. Okay. So how do these patients present to you? These patients present with usually with a poorly functioning kidney and associated features, or recurrent UTIs, or pain in the abdomen. So this has a very specific diagnostic sign which you can see on imaging, contrast imaging of the pelvic calyceal system. What are the modalities with which we can do contrast imaging of the pelvic calyceal system? Please somebody stand up and try to answer. Please stand up. What is your name? Naam bolo? Ayushman. Can you tell me what are the possible methods to image the pelvic calyceal system, the kidney system, what are the ways to image it? How can we image them? USG does not give contrast usually. Anything other than that? Somebody you stand up, tell me. CT, contrast CT scan. Anything else? Have you heard of intravenous pyelogram? Anybody's heard of intravenous pyelogram? So, intravenous pyelogram, contrast CT scan, contrast MRIs, everything involves injecting a certain dye, a certain compound, a chemical compound into the veins of the body. After injecting, we image the body. In case of intravenous pyelogram, it's a standard X-ray. In case of CT scan, it's a CT scan. In case of MRI, it's an MRI. And the image provides a dedicated picture of the pelvic calyceal system of the body. You see, rest of the abdomen, only the system that bears the passages of the urine are visible. So, the kidney calyces are visible, the renal pelvis is visible, the ureter is visible, and the bladder is visible. It is because it is a compound which, after injecting and waiting for a certain period of time, it eventually, after renal filtration, enters the pelvic calyceal system, forms a part of the urine, and this urine gets highlighted when we take some photograph. So, in such photographs, ureteroceles give a picture like this. You see, there is a cystic dilatation at the end of the ureter in the region of the bladder. Sit down, sit down. So, this looks like a snake, doesn't it? This is the head of the snake and this is the body of the snake. Does it not look like the snake? So, this is called the adder head sign. Adder is a type of snake. So, this is called the adder head sign and this is found in ureteroceles. Okay. This is very pathognomic and very important for MCQs also. So, with this diagnosis, we know that with this picture, we know that this patient is suffering from a ureterocele. So, once we get a diagnosis, the next part of investigation on evaluating any patient suffering from any disease, we need to do further evaluation considering two important points. One is we have to look for other commonly associated anomalies with that current condition. So, what are commonly associated with an ureterocele? Please stand up. Tomar naam bolo? Srija. So, what other anomaly have I discussed previously that is very commonly associated with a ureterocele? Do you remember from the last class? Very good. Vesicoureteral reflux. So, in cases where the system is duplex, there are two pelvic calyceal systems draining one kidney, it is commonly seen that one system eventually ends as a ureterocele and the other system gives rise to vesicoureteral reflux. So, we need to rule out that by doing a voiding cystourethrogram, which means again we put some kind of a radio opaque dye inside the bladder, ask the patient to void, and once on voiding we take a photograph and sit down, and on voiding we take another photo to see whether there is any reflux or not. Okay. And nuclear imaging is done to see whether there is deterioration of renal function or not and whether there is any significant obstruction or not. So, this is how we evaluate a patient with ureterocele. We do a cystoscopy to see this picture. Can you see, this is the inside of the bladder and there is one cystic dilatation like this. This is the picture, this is the actual photograph of a ureterocele. So, what do we do with this patient? If this patient has come to us with an obstructed system harboring an infection in that particular system, then like any approach to deal with a system which is infected with purulent material or any collection which is infected, we need to drain the system. Same here, we need to drain this system. How do we drain this system? We put an incision with a laser like this. There is a laser. We put an incision in this cystic part of this part of the cystic swelling. What does it do? It opens up the cystic swelling like a cover, it opens the curtain and it makes easy drainage. So, endoscopic treatment of this ureterocele is endo-incision of the ureterocele, which makes the system open, relieves the obstruction, and final definitive treatment involves re-implantation of the ureter into the urinary bladder, bypassing this ureterocele part. I will come to that in details. Just remember that endoscopic treatment is endo-incision to relieve the obstruction, and ureteric re-implantation is the definitive management. I have written a third option called upper polar nephrectomy with ureterectomy. This is if suppose this particular system is having ureterocele and this lower system is having reflux. Because of the obstructive nature of the ureterocele, this part of the kidney, this half of the kidney is non-functioning and giving rise to only symptoms and no renal contribution to the body. So, at that time we decide to remove the entire affected half of the kidney, ureter up to the ureterocele. So, that operation is called upper polar nephrectomy with ureterectomy. Clear? So, this was in very brief about ureteroceles and how to assess them, how to manage them. Next we come to vesicoureteric reflux. This is also has very close association with ureteroceles, as we have discussed slightly today and in details in the previous class. So, what is vesicoureteric reflux? What does reflux mean? Yes, anybody? Backflow. Yes, it can be viewed as backflow. So, what usually happens is urine is formed in the kidneys and the flow of urine is always unidirectional from the kidney via the ureters into the bladder. So, what mechanism in the body maintains this unidirectional flow of urine? There must be something to maintain it. So, there are two very important mechanisms maintaining this. One is the peristalsis in the ureter, which propels the urine forward. Okay. So, there is only peristalsis in one way, from the kidney towards the bladder, and the other is a engineering marvel by the body. So, what is this engineering marvel? The site at which the ureter enters the bladder, it enters from the outside, it traverses the wall of the bladder and then opens into the bladder inside at the level of the bladder mucosa, right. So, it suppose this is a wall of the bladder, it enters here, it traverses this length inside the bladder wall and then comes out and then drains the urine. So, this part of the ureter which is inside the bladder wall is called the intramural part of the ureter. So, how does this intramural part of the ureter work? This intramural part of the ureter normally has been seen that the ratio of the length of this intramural part from here to the diameter of the ureter is usually 5:1 in a normal human being. What does this do? This, when the bladder fills with urine, there is stretching of the bladder wall. Upon stretching of the bladder wall, this part of the ureter gets compressed by the muscles of the bladder wall, and it acts like a valve which prevents urine from flowing back inside the ureter when the bladder is contracting. Did everybody get what I am saying? Did you understand what I am saying? So, the bladder, when it stretches, it pushes on the intramural part of the ureter, and this push prevents urine from entering from the bladder into the ureter, which is actually reflux. So, once we have a problem with this ureteric tunnel length to diameter ratio, any structural anomaly leading to a change in this orientation will give rise to a reflux. Okay. So, this is a very basic understanding of reflux. It is more complex, however. So, So any problem with these mechanisms will lead to reflux. Now reflux is of basically two types. It is a primary reflux, primary vesicoureteric reflux, or a secondary vesicoureteric reflux. Say any disease, if I say it is primary or it is secondary, it means that primary is always affecting that particular organ, that is that particular part of the organ or that organ which is diseased. For example, if I say a primary bladder stone or a secondary bladder stone, it means stones which are found in the bladder and stones which are found outside the bladder coming and residing in the bladder. So primary, secondary is similar everywhere. Similarly here also, primary deficiency at the vesicoureteric junction, any problem in this particular anatomical structure gives rise to a primary VUR, and other diseases which leads to problems of the natural anti-reflux mechanisms give rise to VUR. What are those things? Most commonly, any disease that increases the pressure of the bladder, increases the pressure inside the bladder beyond its normal capacity would give rise to VUR. What might increase the pressure inside the bladder? If there is an outflow obstruction, if there is an obstruction to the normal outflow of the bladder, which is the urethra. So a bladder neck obstruction or a bladder neck dysfunction, any of these kind of diseases producing obstruction to the natural outflow of the bladder may also give rise to a secondary vesicoureteric reflux. What is the presentation? Presentation, once again I had mentioned previously, it presents from since the baby is inside the womb of the mother. Nowadays antenatal scans detect antenatal hydronephrosis, and vesicoureteric reflux is a very important and common cause of antenatal hydronephrosis. Other than that, patients or young children present with recurrent UTIs and urosepsis. The kidneys might eventually become grossly hydronephrotic and swollen and become palpable, and eventually with features of renal failure. So CKD. So these are the common presentations of patients with vesicoureteric reflux. So for this reason, it is recommended that any child less than 5 years suffering from recurrent episodes of UTI be evaluated for vesicoureteric reflux. Okay. So how do we evaluate for vesicoureteric reflux? I have just mentioned in today's class. Somebody again please volunteer if you can remember from today's class. What is the diagnostic modality to, most common diagnostic modality to diagnose a vesicoureteric reflux? Voiding Cystourethrogram or micturating cystourethrogram. So any young patient suffering from any of these conditions, any of these presentations, hydronephrosis on an ultrasound, recurrent UTIs should be evaluated by a voiding cystourethrogram to look for presence of vesicoureteric reflux. Okay. So on the left hand side of the screen, we see a pictographic depiction of grading of vesicoureteric reflux. So how does this grading happen? Grading is done to assess severity of this disease. So on this side, this is the grade 1, where only the ureters are visible on your VC. Only the bladder is visible, and the reflux contrast media has reached only the ureters, and the ureter is usually of normal caliber, that is grade 1. Gradually the severity of reflux increases, and we see that grade 2 shows visualization of the entire pelvic calyceal system, grade 3 shows dilatation of the pelvic calyceal system, loss of cupping of calyces, and so on and so forth. And then eventually we see a totally hydronephrotic kidney with tortuosity of the ureter, which is a grade 5 reflux. So gradually increasing in severity with increasing in grade. Okay. So again, diagnosis, as I said, it involves performing a VCUG or MCUG, both are the same. Okay. So this photograph you are seeing, this is again some contrast is present in the genitourinary system of the patient, and we have taken a photograph. So, a similar photograph can be seen in another study. Can you tell me which study? If I inject contrast into the veins of the patient and after that we take this photograph, it is called a intravenous pyelogram. And if we introduce contrast into the bladder of the patient and then ask the patient to try to void or pass urine and in the process take this photo, then this is called a micturating cystourethrogram. So, if this is a IVP, then this is a patient with hydronephrosis. We cannot say that this patient is having reflux or not, but this same picture, when this is VCUG, this patient is having reflux. My intention of saying this, mentioning this, was to tell you that a picture like this does not always mean it is a IVP or an MCU. You need to know before giving forward a diagnosis what kind of investigation has given rise to this photograph. So, again, like I said, once we have a diagnosis at hand, our evaluation would be to assess the complexity of the diagnosis, assess the associated anomalies, associated problems that can arise with the disease, and for that we need to rule out a duplex system, ureterocele, and a PUJ obstruction. I have taught in the last class. All these things may be associated in a patient with vesicoureteric reflux. So, now how do we treat this patient? So, there are a general principle, guidelines or principles for managing this disease. Most importantly, there is scope of spontaneous resolution of vesicoureteric reflux with increasing age. What do I mean by increasing age? If this reflux disease was diagnosed at birth and it was an early stage reflux, say stage 1, a grade 1 or grade 2 reflux, and diagnosed at birth, there is high possibility that this reflux would spontaneously resolve on its own. Okay. But with increasing grade and complexity of reflux, this rate of spontaneous resolution goes down. What is the goal of treatment for reflux? The goal is to prevent recurrent UTIs due to reflux, and then by preventing recurrent UTIs, eventual progressive renal damage. Okay, we have to prevent eventual renal damage. And third is that for high grade refluxes, surgical treatment or surgical correction has very high success rate. So, these are the guidelines, these are the principles for treating a patient with reflux. What are the treatment options? One is medical management. Medical management is meant for early reflux when we are waiting for spontaneous resolution or keeping the patient under follow-up. So, what are the options for doing that? We need to give the patient antibiotic prophylaxis to prevent recurrent UTIs, a proper bowel habit management, because associated constipation usually deteriorates the condition, double voiding and anticholinergics. I shall explain this to people who are interested. This is slightly complex. Number 2 is surgical management. What is the surgical management of this disease? So, again, once again, this is a disease involving the vesicoureteric junction mostly, in primary cases at least. In secondary cases, we need to treat the distal obstruction or the whatever the primary cause is. Whereas in a primary VUR, we need to treat or surgically correct the vesicoureteric junction. This is again done by most commonly an ureteric reimplantation. We reimplant the ureter at a new site which has a proper 5:1 ratio. We try to do that. Okay. I have also mentioned another endoscopic injection management. This is a endoscopic procedure whereby, if I go back to this picture here, what we do is we introduce by injecting inside the bladder at a place over here. You see, this is the opening of the ureter and this is the entry of the ureter at the outer bladder wall. So, this part is important for for the coaptation of the ureteral walls, and in VUR that is deficient. So what we do is we put in a needle like this over here, and with that needle inside below the ureter above the muscle layer, we introduce certain gelatinous substances which remain inside and do not get dissipated to provide bulk below the ureter and above the bladder wall. So it increases coaptation. Did you understand what I am saying? So it increases the pressure inside the ureteric, right outside the ureteric orifice. So this again is an endoscopic management. It's called deflux injection, submucosal injection below the ureter, and the gold standard treatment is ureteric reimplantations. Okay. So vesicoureteric reflux, I don't know the new question what is the question pattern that do you have your question patterns? What is the question pattern like in your final examinations? Do you have long questions? Do you have short notes? How many short notes, how many long questions in the new format? Long question duto or short notes? Long question or baki? MCQs. Okay. So it has changed. I think in my times these 4 topics were common as short notes, 5-mark short notes. They were very commonly given. I don't know the current pattern now though. I have to know it from you people only. So this is all that we need to know about vesicoureteric reflux at your level. Third important topic is posterior urethral valves. Okay. So what do we mean by posterior urethra? What are the parts of the urethra? So if we draw the ureter, this is the bladder and the ureter is going out like this. So there are 4 parts to the urethra. One is the region where usually the prostate is present. This is called the prostatic urethra. Okay. After the prostatic urethra comes the membranous urethra. Okay. Then comes the bulbar urethra. Then comes the penile urethra. And at the end of the urethra there is the fossa navicularis, which is housed inside of the glans penis. Okay. So these are the part of the urethra. Now this disease that I am going to discuss now is a posterior urethral valve. So posterior, this part is called the posterior urethra and this part is called the anterior urethra. So any obstruction in here, this part is called a posterior urethral obstruction. So this disease is called posterior urethral valve. It is a congenital disease. It's a congenital membrane that is creating an obstruction at the level of the prostatic urethra, the level of the bladder neck to prostatic urethra. So what happens is it is a membranous fold within the lumen of the posterior urethra. As you can see, I don't know whether you can understand this picture. This is the picture of the bladder and the urethra cut open from the front and we are viewing from the top. So this is the bladder, this is the trigone of the bladder, this is the prostatic part of the urethra. Now do you see these structures on the side? This is the urethral canal and these structures on the side are trying to depict a valve which is a partial obstruction to the flow of urine from the bladder to the urethra. It can be of several types, 3 types basically, depending on the orientation of the valve inside the urethra. It can be slanting from forward below to distal upward or the opposite, or it can be one membranous with a very small hole in the middle. These are the types, but what this valve achieves is a partial obstruction to the flow of urine of the urethra. What is more important is that this obstruction is present congenitally, not since birth, even prior to birth. Okay, so when the fetus is growing inside the body, since then the flow of urine is obstructed. So what happens to the urine when it is inside the uterus, inside the womb? What is the role of the urine? Does the fetus pass urine inside the womb? It does. So what happens to this urine? Yes, it gives rise to amniotic fluid. It is a major constituent of amniotic fluid. So if there is an obstruction to this flow, there is decreased urine output, and so there is decreased amniotic fluid. What is that condition called? Decreased. There is less amniotic fluid. Very good. Oligohydramnios. So oligohydramnios, have you studied oligohydramnios in gynecology yet? Yes. So have you studied the effects of oligohydramnios on the baby? Everything that happens due to oligohydramnios happens in posterior urethral valve, and since birth, so its extent or its magnitude is very high. So it has a very bad consequence. So what happens? This obstruction creates a local dilatation, a bulging of the part of the urethra just before the valve. This gives rise to something called a keyhole sign. Okay, we call this a keyhole sign. This keyhole sign is visible on ultrasounds, on any kind of contrast studies. So what happens? There is congenital obstruction, and because of this obstruction, there is severe hypertrophy of the bladder wall. The bladder muscle is trying to overcome this obstruction, and it has become very muscular and hypertrophied with very high voiding pressures. What happens if there is outflow obstruction and very high voiding pressures? There is reflux. So there is bilateral reflux affecting both the kidneys. Both the kidneys are hydronephrotic. There is progressive functional loss of the kidneys, eventually leads to chronic kidney disease. So, okay, so this is the part affecting only the this is the only genital urinary part that I mentioned. Apart from this, because of oligohydramnios, there is a huge range of problems that the patient suffers from, the most important among them being decreased lung compliance, pulmonary hypoplasia. Why does that happen? Because it is the same amniotic fluid which bathes the lung and prepares the lung till the baby comes out of the womb and gets exposed to air. So this absence of adequate amount of amniotic fluid gives rise to a severe consequence in the baby called pulmonary hypoplasia. Often this is the becomes the determining factor in very young infants. Other than that, as we have discussed, the kidneys, there is progressive glomerular injury, and it leads to something we called as dysplasia. You have read in your pathology classes what is dysplasia, what is metaplasia. So there is eventual dysplasia due to this progressive renal damage, and which becomes irreversible at a certain point of time. The bladder, as I mentioned, becomes thick walled, becomes non-compliant, and there is myogenic failure. What does myogenic failure mean? That after developing so much of muscles, the person becomes difficult, it becomes difficult for the person to move around. Similarly, in this case, the bladder the muscle is not functioning normally, so it leads to incontinence and overflow. And lastly, the ureters are also poorly contractile because they are distended and they fail to carry urine. So this is a very bad disease to have, and most of the patients eventually lead to CKD. How it presents in newborn with a palpable bladder, respiratory problems, uremic picture in biochemistry, and recurrent UTIs in the slightly older toddler age group. It is diagnosed by bilateral hydronephrosis, a dilated posterior urethra, as it shows in the two photos, It is called the keyhole sign. Increased renal echogenicity depicting renal dysplastic changes, and oligohydramnios is visible in the antenatal scans. Okay. What do we do? Our goal is again to drain the urine first and then think of final better model, definitive treatment. So, catheter drainage is the first target. If catheter drainage is possible, then eventually treatment is done after stabilization of the patient with either of these two methods. What determines if the caliber of the urethra is broad enough for us to introduce the instruments needed for this operation, then we proceed with something that we call endoscopic valve ablation. You see, this is the pinpoint hole. In this urethra, this part of the urethra is covered by the valve. In this urethra, both the sides are covered by the valve. So, our intention is to cut those valves and release the flow of urine. You can see in this photo also, by this technique, we use various modalities like laser or like that to cut these valves and open the urethra. If that is not possible in the first phase because of narrow caliber of the urethra, we make a diversion higher up. How can we make a diversion higher up? We make an opening into the bladder and connect it to the skin. It is called a cutaneous ureterostomy. So, the urine continuously dribbles out of the bladder into to the outside. If the catheter is not possible, again we proceed with vesicostomy, cutaneous vesicostomy or ureterostomy. So, that is all you need to know about posterior urethral valves at present. Now, two very important topics are left behind. I don't know, I might need to oversee your classes. Hypospadias and cryptorchidism. So, hypospadias. What do we mean by hypospadias? Have you heard of this disease called hypospadias? Yes, you heard of it. Good. So, hypospadias involves the basic tenet of hypospadias is that the opening of the urethra in the male child is not at the tip of the glans penis where it is normally supposed to be. Okay, it can be anywhere starting from away from its natural position, which is here. Its natural position is somewhere around here at the tip of the glans penis. So, opening of the urethra anywhere before that is called hypospadias. So, it involves a large range of problems. It can open somewhere in the glans penis itself, but proximal to its natural position. It can open into a part of the junction between the glans penis and shaft of the penis called the corona. So, these two are called glandular or the coronal hypospadias, and then it can open anywhere from there to the perineum, which is called middle or proximal hypospadias. Why does this happen? Why does this happen? So, we have to go to the embryological development a little. Are you with me, everybody? So, if we look at the child, if we look at the developing embryo from below, there is opening of the cloaca like this, okay, from below, and if we look at it from the side, it is like this, the cloaca is like this, opening at to the lower part of the body like this. So, this is the opening of the cloaca. This cloacal opening is surrounded by a cloacal fold on its either side and a genital fold just outside. You see the two color marks, the genital fold and the urethral fold, and on the anterior part of this fold there is a tubercle called the genital tubercle. So, this entire cloacal fold eventually splits into two, called this creates the urinary opening and this creates the anal orifice. So, surrounding this urinary opening is the urethral fold, and at the top of this is called the genital tubercle. So this gradually enlarges. This urethral fold, when we are seeing it from the side, this is the urethral fold and it is covered on top by the growing genital tubercle like this. Is it visible and did you understand? So if we again cut this from here, we will see a growing genital fold like this and the urethral fold inside like this. Okay. So this is how the penis starts to form in the body. So this tubular structure is basically semicircular. Can you see? The upper part is by the genital tubercle and the side part is by the urethral fold. This is how the penis or the phallus is formed in the body. Now, just like a zipper mechanism, these folds start to unite in the midline over here. And where does this union start? It starts at the back and gradually proceeds to front. So in this picture, I don't know whether you can understand. If you go through your books, you'll understand better. So this is the penile urethra. The zipper starts from here to close the urethra from back to front like this. So from the perineal region to the tip of the penis. So any problem in eventual closure of this tube give rise to hypospadias. So the midline closure does not happen and where it stops, the urethral opening eventually houses itself there wherever on the shaft of the penis. So the closure like this can stop here. It will be a perineal hypospadias, scrotal, pinoscrotal, proximal penile, mid shaft. So anywhere the closure has stopped, there the orifice is of the urethra is seen. Okay. So this is the most important problem, but this is not the only problem with this deficiency of closure of the tube. What is associated with it? Because of this deficient closure, there is abnormal ventral curvature of the penis. So normally the erect penis is straight, whereas in these cases there is ventral curvature of the penis. The penis is bent in front like this and it is also associated with abnormal distribution of foreskin. The foreskin is also supposed to come and join in the ventral surface, which does not happen. So there is accumulation of foreskin as a hood like a snake on the upper part of the penis. Did you get even a little bit of idea? It improves, the understanding improves when you study yourself, but my intention is to make your understanding easier when you are studying. So this tube elongates as a semicircle, forms the phallus, then starts to tubularize from backwards to frontward. Anywhere it stops tubularization, that is the site of the hypospadiac urethral orifice, and it is associated with two more problems: ventral curvature of the penis as well as dorsal hood of skin. So this is a complex of hypospadias. Okay. So how do we diagnose it? Clinically, by seeing and identifying whatever I just mentioned. Okay. So clinical diagnosis you have to do, and again you have to rule out other problems that can be associated with it. It is often associated with cryptorchidism and prostatic utricle. Now, a child has hypospadias. Why does he need treatment? He needs treatment. One, if it's a hypospadias, say involving till over here, what might be the problem? The problem is, number one, when the child is passing urine, the urine is not a stream directed forward, it is a stream directed below. Okay. And number two, when this child grows up, it will be difficult to bear children because the semen will also not be deposited in its proper place. So this needs correction because of two very important issues. One is cosmetic and two is that it needs to serve two basic functions of the penis, that is proper egress of urine and sperm. So surgery indication is a proximally located stenosis, proximally located meatus, a meatal stenosis and a severe chordee. One thing must be borne in mind, that a child born with a severe hypospadias associated with cryptorchidism. Cryptorchidism means absence of testis, should be evaluated for DSD. DSD, what is DSD? It is disorder of sexual development. So one has to evaluate the child for any DSD associated for that. So for this child, what is the ideal time for surgery? Often asked in examinations. The ideal time for surgery is 12 to 18 months. Why? By 12 to 18 months, there is slight development of the tissue. The child is slightly bigger, easier to manipulate. Healing is good. And by what time do we need to perform this surgery? It is essential to complete the surgical procedure. This is often a multi-stage procedure. So it is important to complete the procedure before the child goes to school. Why so? Because it is a very big social stigma if a male child goes to the male toilet and cannot void in the standing position. If he has to sit and void, then it becomes a social stigma, becomes a source of depression for the male child. So before the child goes to school, we need to complete the treatment for hypospadias. Okay. So the ideal time to start surgery is 12 to 18 months, and the surgical procedure treatment should be complete by preschool. So what are the things we need to correct, we need to do for treating this patient? One, you see I have written 5 things over here. Orthoplasty, urethroplasty, meatoplasty, granuloplasty and skin coverage. So these are the 5 problems that we need to address separately in sequence. You see this picture shows the chordee, the ventral curvature of the penis. So the first step is orthoplasty, is to correct this ventral curvature. Okay. So this is orthoplasty. Once orthoplasty is done, the ventral curvature is corrected. Now we need to correct the position of the urethra. Urethral orifice repositioning to the tip is called ureteroplasty, to create the rest of the urethra which was deficient. There are various ways to create urethra. You need not go into so much detail, but the second step is ureteroplasty, to create the new urethra with local or distant tissues. Once the ureteroplasty is done, then we need to create the new meatus, the new site of opening of the urethra into the glans penis. That is called meatoplasty. Once the new meatus has been done, we need to reposition the glans penis around the new urethra. That is called granuloplasty, and eventually we need to cover everything with local skin flaps harvested from the penile skin itself. So that is skin coverage. Did you get a basic idea of the sequence of events that we need to do? So first correction of chordee, then correction of the urethra, make the new urethra, position the new urethra at the tip of the glans, cover the urethra with the glans penis, and finally cover the entire defect with skin. Now this may or may not be achieved in a single stage surgery. It can require 1, 2, 3 sittings, and what is more important is this kind of surgeries have very high failure rate. Once corrected, may not eventually give rise to the perfect requirement. It can lead to repeat fistulas, repeat hypospadias or skin necrosis. There are a lot of complications associated with it. So we need to remember that it can be multi-stage surgeries, there can be multiple failures, but treatment needs to be started around 12 to 18 months and it should be completed by the time child goes to school. Okay. Now possibly the most important topic, but I am starting very late for this. For you, most important topic, I had this topic as my short case when I was giving my MBBS examination. So, this can be your short case also in your Viva practicals. Do you have short cases in Viva practicals anymore? Short case, long case you still have, right. So, cryptorchidism, what do we mean by, do you have class immediately after this? Okay. So, cryptorchidism is absence of testis in the scrotum. Basically, you can't find the testis, it is a hidden testis. Why does this happen? We need to delve back to embryology a bit. If you can remember from last class, the testis develops right beside the kidney at the T10, T11 level over the posterior abdominal wall as a gonadal ridge. Okay. Now, this testis gradually descends and the kidney gradually ascends. You remember ascent of the kidney. So, descent of the testis happens inside the from the T10, T12 level to the scrotum at birth. How does this happen? The testis, around the 3rd month of intrauterine life, the testis reaches from the T10 level to the iliac fossa. Then around to 4th to 6th month, it reaches the internal or the deep ring, progresses the deep ring till the 7th month, and after the 7th month, it traverses from the deep ring to the scrotum. So, this is the timeline, you have to remember this timeline. And one more thing you have to remember from embryology is that what is the driving force behind this descent of testis. So, there are a lot of theories as well as controversies. What we have finally come down to believe right now is the main driving force of the descent of the testis is differential growth of the abdominal wall and the bony structures. So, the growth of the vertebral body and the pelvic bone structures and the growth of the musculature of the body happens at different magnitudes, different paces. So, this is the main driving force, assisted by multiple factors. The important factors are that increasing intra-abdominal pressure gradually pushes the testis down towards the deep ring, and also it is assisted by something that is called a gubernaculum. So, gubernaculum is a thickening of mesenchymal tissue, which is one end of which is attached to the caudal end of the testis and the other end is attached to the lower part somewhere in the scrotum. Now, the general consensus initially was that the gubernaculum pulls the testis down, but that is not the case. Gubernaculum basically guides the testis to its right position by gradual resorption. So, there is this rope, the rope gradually resorbs and the testis finds its way towards the deep ring, superficial ring and finally scrotum by the pathway of the gubernaculum. Okay. So, now if the testis is absent in the scrotum, it can be multiple options basically. One is it can be a retractile testis, that there is the testis is there in the scrotum few times, but due to a very heavy cremasteric reflex in that particular individual, the testis is often pulled up due to the cremasteric reflex. It can be a palpable undescended testis. What do we mean by palpable? It can be in that part of the abdominal cavity which is amenable to superficial palpation. Okay. So, around the inguinal region. It can be a non-palpable undescended testis, whereas the location of the testis is beyond the scope of clinical palpation. So, possibly it is somewhere near the deep ring or further up, or it can be an ectopic testis. What does that mean? That means the testis has deviated from its normal course of descent and is possibly present somewhere other than the normal course. What might be the other sites? It can be a suprascrotal, prepenile, so there are a list of places where it can be, and it is often asked in your examinations in Vivas, what are the common locations of a ectopic testis. Another very important thing is that whether the testis was ever there in the scrotum or not, whether this is actually an undescended testis or the testis has vanished later on after its normal descent. This is a very important clinical aspect to it. So, how do we decide whether the testis is was actually ever had actually ever descended or it has not descended? It can be presumed by, it can be anticipated by clinical examination of the scrotum. So, on visualization of the scrotum which has once harbored the testis will have a specific characters. Number one, it will be thick walled. The scrotum will be thick walled, capacious. There will be rugosities on the scrotum. It will be pigmented, and both the sides of the hemiscrotum will be differentiated by a very prominent median raphe. So, a scrotum which has once housed a testis will be slightly darker than the surrounding skin, will be having rugosities, will be capacious, and these are the clinical features which denote whether there is an undescended testis or not. So, how do we go about this patient who is suffering from an undescended testis? First and foremost, clinical examination is very important because we have to see whether this is a palpable testis or an impalpable testis. So, a palpable testis, if it is present at a palpable region, my idea should be to position the testis at its normal position, to approach the testis inguinally, release the testis by preserving its blood vessels and gradually placing it in the scrotum. Okay. So, this operation is called orchidopexy. Now, if the testis is non-palpable, then it can be two things, that I cannot palpate it properly or it is not present in the palpable area. So, my first step would be to do an ultrasonography scan of the inguinal region to look for a testis. If it is not there, then we have to presume that the testis is inside the abdomen, and we have to follow that up by doing an examination under anesthesia followed by laparoscopy. Okay, laparoscopy to find the testis. So, you might be thinking that looking for the testis inside the abdomen is similar to looking for a needle in a haystack. It is not so. We have to look for specific sites where the testis along its natural path of descent. So, this is a part of the abdomen around the deep inguinal ring where most commonly testis is found if it is intra-abdominal, and our work, our job as surgeons is to identify the testis, release it from its intra-abdominal attachments and gradually position it inside the scrotum. There are multiple surgical approaches to do it, multiple ways to do it. You need to know the name of one particular surgery that is called a Stephen Fowler technique. Stephen Fowler technique is very interesting actually. You know, the testis is present inside the abdomen and we are trying to pull that structure down. So, if I try to pull this particular curtain from that window to this window, there will be an obstruction. Why? There will be a pull. I might not be able to bring that curtain from this window to that window. So, in that case, the biggest obstacle in case of bringing down the testis is often the arterial supply to the testis itself. The artery prevents its descent. So, what do we do in that case? In that case, our surgery is a two-stage surgery. We clip the artery, we block the blood supply to the testis by the main testicular artery. So, what happens then? The testis is also has some other minor supplies which are by the cremasteric vessels and the vessels to the epididymis. Okay, vas, epididymis and cremasteric vessels also has minimal supplies. So, once we clip the testis, these supplies eventually start to supply more blood to the testis, and say after 6 months time we go back in again and release the testis and put it back to its normal position. So, it can be a one-stage process, it can be a two-stage process. Two-stage process is called Stephen Fowler technique. Now, the last thing for today, actually the most important thing possibly, is that last class I had mentioned in case of kidney, suppose it is an ectopic kidney. So, do we try and mobilize the kidney and position it in its normal position? No. So why do we try to do it in case of a testis? What is the idea behind it? So the two major problems that a person can have with an intra-abdominal testis is, number one, inaccessible. I mean, for sperm production, the testis should be located outside the body where the temperature is slightly lower than what it is inside the body. It helps sperm production. So testis present inside the body will suffer from subfertility. Okay. So if we have made the diagnosis early in life, it is prudent or better for that individual to have the testis brought down to its normal position, but it is not the only reason. What are the other reasons? Any condition affecting the testis will not be evident to the normal eye. It will have a masquerading effect. See, a patient with the right iliac fossa pain, couple of years from now you will be making a clinical diagnosis of appendicitis. However, if this patient is having an undescended testis, it can be a torsion of the testis inside the abdomen also, masquerading as acute appendicitis. You understand? But more importantly, testis inside the abdomen has more chances of developing germ cell tumors. So by putting it out, taking it from inside the abdomen and taking it out into the scrotum, does it reduce the chances of developing germ cell tumors? Not significantly, but what does it do? It makes the testis accessible to clinical examination. You understand? So even if I am not totally abolishing the chances of a malignant transformation, I am making it amenable to clinical examination, so that if anything happens, it is right in front of our eyes to clinically detect and then proceed with treatment. There are a lot of other things to discuss about cryptorchidism, possibly surgery practical classes deal with it, and if I take a class again in the future, I will also try to complete and cover a few other topics. Any questions in mind? Anything you want to know or you did not understand or I was not clear about?